Well, first of all, thank you very much for the invitation, and it's great pleasure to speak with all of you and many of you, for all of you are clinician. And I think this is really appropriate occasion on the heel of the, I would say, the first successful clinical trial for the use of gene therapy to treat human genetic disease, genetic hearing loss. So I'll just claim all this conflict of interest here. So what I'll do today is really to give you a kind of a rundown how we actually, initiate the study and how that study fit into overall thinking of our overall goal of developing treatment for genetic hearing loss. And of course, I'll take you through all the experiment we've done and all the works being accomplished, what we learned, and importantly, what this holds for the future. I think that's really pertinent to everyone at today's meeting. So everyone knows we have a major issue with hearing loss. There's an enormous number of people affected by a variety of hearing loss. And for children, the problem is really prominent because it affects the speech, the brain development, and large percentage of children actually, their hearing loss is caused by genetic mutations. And so that's actually is one of the major drive for all of us trying to develop a treatment for children, at least to begin with, and to help them. So the problem we're dealing with now, if we use the existing data, is over 1.5 billion people suffering varying degree of hearing loss, and by 2050, it's probably, the numbers increase drastically. Of course, the effect on the individual, family, society is enormous from different perspective, and from children, adolescent, all the way to elderlies. And the other thing is, of course, is a huge cost. Not only, the health cost, suffering, all the things, but also on the economic side, not only for the treatment itself, but the loss productivity, everything else to go with it. So really, there's a real incentive to develop treatment. As we all know, for all you sitting here today, we actually don't have any treatment for hearing loss, at least in terms of the drugs or biologicals. One of the focus for our teams really on the genetic deafness. We know now there's over 150 deafness genes have been discovered, and they can be, they really cover a garden variety of genetic deafness, could determined by how the sort of genetic deafness is transmitted. It could be recessive, could be dominant, or X-linked mitochondria. And so there's a distribution, and large majority of them is actually due to the recessive. That means the loss of both copy of the functional genes that lead to the hearing loss. And of course, many hearing loss, genetic hearing loss could be due to manifest syndromic or non-syndromic. Syndromic means, that come with other distinct phenotype, such as Usher syndrome. You have a blindness together with a hearing loss. And so many, like Norrie disease, which is Zheng-Yi clone many years ago, come with, blindness, mental retardation, hearing loss altogether. But increasingly, actually, as we found out, more and more genes and mutations affecting not only children, also we start identifying them in the elder population, elderly. So because elderly is very difficult to study, and it's very mixed cohort. So we don't have really a good way to identify what is the gene, what is the prime drive for like an age-related hearing loss. But we think the genetic mutation component and play a very important role. That's something we're also working on very diligently. So, but to begin with, you're in a House Ear Institute, you don't need to be reminded. We have a terrific device to treat severe, profound hearing loss, which is a cochlear implant For the less, moderate to mild, we have hearing aids, but of course, it comes with all the limitations. And despite of the improvement over decades, as the first cochlear implant was done over 60 years ago, and so we really, despite all the development in the modern biology technology, we really still lack a major sort of progress bringing a new type of treatment for hearing loss, including genetic hearing loss. But I think that somehow is changing in the last a decade, not a few decades, just last decade or so. So we've witnessed a tremendous progress in developing different type of treatment, especially gene replacement therapy to treat genetic deafness. And we and others have really pioneered the work using editing, gene editing, to treat a type of genetic hearing loss, such as dominant hearing loss in animal model. And the other group, such as Richard Smith, and they have used siRNA as an alternative strategy. But so those are the sort of treatment paradigms actually upcoming, and we'll see the sort of outcome in the near future. But I think there's a really even more really interesting, exciting opportunity that's in the area of regeneration and drug therapy. And we, and as well as others, really putting a lot of effort in those areas. We see a lot of really good design. So I'm really hopeful down the road that we can also develop a brand new treatment along those lines. But today, we really trying to focus on gene therapy for otophoring. So when we try to develop a therapy, gene therapy for genetic deafness, what is the considerations? Why do you choose this one over the other one? Why do you know, what's the odds one will work better than the other one? So really, here are some of those criteria we use to specify, to identify what type of hearing loss we want to target to begin with. So first is we really need to know what's wrong within a year. Okay, so if you have genetic deafness, normally the large number of cells have been infected. I mean, could be a garden variety, but we need to know. So we need to know the pathology, because in a year we cannot get human temporal bone in general for genetic deafness. So us really solely rely on animal model. The other one is we need to develop a strategy. You need to develop an animal model to show the hearing loss can be treated. The treatment, we actually use a different type of definitions. One is if people already lost completely without hearing, the treatment means you can reverse the hearing loss, regain hearing. And but in some cases, people have gradual loss of hearing loss. So in that case, after treatment, preferably you can reverse hearing loss, regain. But more often than not, at least in our opinion, we probably will achieve most likely is it's almost like preservation existing hearing. That is, after treatment, some patient, the hearing loss will not deteriorate or not deteriorate as fast as untreated ear. Okay, so there's a two definition. I'll go into that later on to show the really very distinct and also the foreshadow the future treatment as well. Then, of course, when we treat animal model, all good and nice, and say animal works, but how relevant that's really to humans? So this really relates to the fact in animal models, such as mouse model, when mouse are born, in the year still develops. So mouse model, even though it's very good to some degree, mimics the human condition, but in many cases, the mouse model doesn't really, in terms of timing, doesn't really faithfully reproduce what's happening in human. So as a result, so many of gene therapy, including genome editing, successful gene therapy, we and others have developed, they actually only work in the neonatal animal, young animal. If you give it an adult, it doesn't work. So what does it say about in the human? In human, turns out in the years fully mature. And so there is a strong incentive to develop treatment. You have to be able to show that treatment is actually working in a mature mouse in the ear. before you have a chance to see any efficacy in human. So that's really one of the key component in the finding, in our thinking. Of course, we want to reduce potential risk, and you want to develop any therapy for any patient population. Ideally, you want to have as many patients possible, right? To have a better source and can get some support from industry and to make it successful. So autofurling, so what is autofurling? Autofurling is, actually play an essential role in the neurotransmitter. It's really, autofurling functions really, localized in the ear, in the hair cells, and in the synapse, and is a calcium-dependent neurotransmitter release mechanism. So for the neurotransmitter to be taken up by the synapse, and for the release after the the mechanical signal transduction and depolarize the hair cells, this process really needs the function of autofurling. And so in autofurling, if you children or adult or anyone without functional autofurling gene, they will develop severe profound hearing loss. Most of the cases are congenital, they're born without any hearing. And it's transmitted as a recessive because you need a mutation in both copies. So this is actually one of the most common form of auditory neuropathy. And as I said, it's localized in the hair cell and involved in exocytosis and neurotransmitter release. So through many studies of different groups, we know where autofurling is localized in vesicle within inner hair cells, and numerous mutations as shown here have been discovered along the gene. So what means any of the gene, you have two mutations, could be the same mutation, could be different mutation, as on the different allele, they can cause DFNB9, which is a congenital difference. So how to develop a treatment for gene therapy for DFNB9? So the approach we used was the so-called AAV-mediated gene therapy. Actually, at the moment, vast majority of successful treatment for genetic disease is all through AAV. AAV is the adeno-associated virus. So basically, this is a virus, and it can, what we do is take the gene, put in a virus, and deliver the gene into the inner ear. The virus will go into the ear, infect the cell you want to target, and produce the protein product that's missing from the cells, and in a way to restore the function. But for autofurling in particular, there's actually extra challenge to the process. That is, the AAV, the adenovirus and associated virus we use has a size limit. That is, the gene it can take cannot be too big. The maximum size is 4.7 kb, but it turned out autofurling is over 6 kb. So we really can put one gene in one AAV. So because that, there have been technological advancement in the field, especially in genetic hearing loss. That is the dual AAV strategy, that by breaking one gene into two halves, so you can imagine one will be like a 3 kb, one point something like that, and each half will be taken up and be packed in AAV virus, and you deliver them set together into the inner ear, and when the two halves of AAV, they both getting the same cells, each half will be reproduced, and as a result, the two parts they can be recombined. They can use a different mechanism. Could be use protein recombination or RNA recombination. The bottom line is, as a result, they can combine to produce a full-length product. As a result, that product is functional. So this work has really laid the key foundation for the autofurling gene therapy in humans. And I want to mention two really study. One is by Tobias group, and the other one is by Larry Lustig groups. They both use a different, strategy, but they all use dual AAV. And they showed that if you use dual AAV, you inject the AAV into the mouse in a year, and you can get the full length of gene product produced and shown here, and the turn green or shown here in this gray color. And more importantly, they've shown in the autofurling and knockout mice, that means the mouse is deaf just as a human, they can rescue hearing. So by injecting this dual AAV into the ear at the neonatal stage, and they can recover the hearing. This injected ear, and they can recover hearing. In this case, almost as good as wild type. And this one is also, it's really good, close to the wild type. Okay, so this work really laid the foundation for the work in the clinical trial and in our work. So we, as the team, we have also used a similar method after them. We actually developed our own method to use the recombination technology, dual AAV, as shown here. We use the inting and use two combined two AAV and make two types of AAV, dual AAV, and for the injection in a year. What we found is we can inject in a year. Indeed, we can recover hearing in the animal model. So we perform two types of experiment. One is to inject in the neonatal animal when in a year still develops. And we can get a very good hearing recovery and shown by the ABR threshold and reduction. On the other hand, we also did an adult injection. So as I mentioned, in a year of newborn mice is still developing. So really to show the methodology can be potentially applied to human, we have to show the whole work can be done in adult animal. So we perform an adult injection, and indeed, we can still see a very good hearing recovery from otherwise completely deaf animals. So this really laid down the foundation for us to move the work into the clinic. So how do we, how does clinical studies done? So clinical work, before you actually go into human for trial, there's a stage, the preclinical for IND enabling stage. That is, you find initially from animal study to show your treatment is efficacious. Then afterwards, you need to study in a wild type animal, preferably from small animal as well as a large animal, in this case, non-human primate, and use a different dose to show your the whatever product you're going to use will not cause any harm. So this is basically, we need to study the biodistribution and toxicology, toxicity. So this is a way to evaluate how safe the approach is. When everything is shown is safe and doesn't have any toxicity, adverse effect, then you can move the work for the human. So in this case, we have like 4 steps. One is for the drug component. We need to find out how drug is being delivered into the, how being produced. And we also want to limit the virus go to the cell type we really want to go and express the gene in the right cell type. We don't want to express gene in some cells we're not supposed to. So that could cause some unforeseen safety issues. Of course, for AAV production, you need to produce an AAV which is a GMP grade good manufacturer product. That means is good and for human trial. And as I said, the first with those products, we want to be sure the from toxicity and biodistribution is really safe in small animal, in mice, and also perform study in non-human primate. So the first is really deliver gene to the right cell type. This is the one that's very early, and many years ago, since Morton Walter Nance published this paper, it's all actually turned out to be one of my favorites. It really shows that when genetic mutation happen in practically every in-the-ear cell types, it can cause deafness. So that means for each gene deafness, you have to target each individual cell type differently. So otoferlin is in this particular one in the ear, inner hair cells. And so we have previously screened many AAV to show various AAV serotypes to find out which AAV can actually target inner hair cells. So it turned out AAV1, as shown here, have really good target efficiency, target the inner hair cells. But other AAV, for example, this UNC80 can target many other cells, outer hair cell, inner hair cell, and some in other non-hair cells. Okay, so that's the thing we need to show which AAV we're going to use. And AAV1 has advantage that has been used in the clinical trial to show to be safe by other different study for human diseases. So the next thing is really to find a way to deliver into the inner ear. How do you deliver that? So traditionally we're using, we can use a lateral wall, cochlear ostomy, round the window membrane, or post-semicircular canal injection route. They all work actually, but in mice at least. But in human, of course, is preferred, more preferably for us to use a round window approach, because in that case, potentially we can go through ear canal to transcanal approach to deliver the gene product. But for this toxicity study, we measured the AAV deliver otoferlin into the wild-type mice and into the adult mice and the monkey. And we showed if you do that, their hearing is not affected. Normal hearing is not affected. So that means there's no toxicity. And the group, especially Eli Shu, a physician who has practiced in a cadaver, and to show similar approach can be used in humans. And we further modified the virus to be sure is really have a very nice transduction. This is the GFP as a reporter to show that's actually in the inner hair cells, as shown here. And transduction efficiency is pretty high, up to 90%, all the inner hair cells can be transduced. So the next is, as I said, actually when you come to the final product, your human study, we need to decide which recombination methodology we're going to use. As I said, there's a different type of technology involved in dual AAV. Could be RNA recombination, could be inting protein splicing. So we evaluate a different approach, and we found out in one particular type, as shown when we use Western to deliver this into the inner ear. This is one is a F1 phage and splicing element that can really introduce very high splicing events. As a result, we can get a very good protein product, full protein product. And this is the one we chose as a final clinical product. So this is how we also evaluated not only by the Western, also by the effect by injecting to the mouse in the ear to see to what degree they can restore hearing. And you can see this is the blue line, which is shown here, restore the hearing to the max effect compared to other different variants. So this is how we landed to use this particular product for the clinical development. The other thing we have also thought about that is, even with AAV, we've shown early on, you can infect the inner hair cells, but we also know those AAV in general, they have other infection pattern which we may not know very well. That is not only infect the inner hair cell, they could infect the other cell types. We don't really know, well, we haven't evaluated. So to really restrict the AAV to hair cell, not only infected hair cell, only in the inner hair cell, the gene will be produced and will be expressed, and protein will be produced. So will not be expressed in the non-hair cell types. So we actually screen the promoter. So the AAV is driven by promoter that will activate the gene expression. So in general, people use the CMV promoter, which is ubiquitous promoter. But in this case, we want to limit the expression otoferlin into just the hair cells. So we actually use existing material, and which is people have found that Mountain 15 promoter actually confer this hair cell, especially inner hair cell specific expression of the gene. So we modify this promoter and build it into the AAV1 and try autofurling expression. So how that works is just show you example. For example, here's a different AAV. If you use a reporter to do the AAV injection into the inner ear, you can see the AAV and GAP in different type of cells, many cell types, okay? But if you use this Mountain 15 promoter driven that, you can limit the expression just to the inner hair cells. So this is how we can be sure the expression of gene will only be in the cells we want to be expressed, not anywhere else. And we show, use this method, we can indeed recover the hearing in a transgenic animal model. And the other thing is what kind of dosage we're going to use for clinical study. This is really key. We don't really know. The only thing we have is animal model. So we basically have to do dose escalation study. You try from low to very high dose. So in this case, from lowest to highest is like a log magnitude, the dosage. And we inject into the animal to see one, for hearing recovery, do we see any differences? Secondly, is at the higher, especially high dose, does that cause any toxicity? So the first, if you look at the dosage even, you realize the higher dose goes, the better the hearing recovery is. Okay, that's the lowest dose, highest dose. Really shows the high dose has best recovery. So that's really give us a range, say, we need to go to a higher dose. This injection in the neonatal animal, this injection in adult, and again in adult, one is we can see sustained hearing recovery in the animal model, and also the highest dose gives the best result. And this is shown by immunolabeling to show the autofurling actually expressed in the autofurling knockout mice in the inner hair cells. So now we know, all those dosage effect. We want to see if you use a different dosage in a wild type animal, not in knockout animal, wild type animal in both mice and the non-human primate. Does any of the dosage cause toxicity? That's what the toxicity in this case. We first compare the hearing in injected over uninjected ear. Hearing is the same. There's no difference. And we look at the number of transducer cells. They are very good. And looking in the ear itself, we don't see any toxicity. There's no hair cell loss or any cell damage. And we did a blood biochemistry analysis to look at all the parameters from the blood. If you compare to the vehicle, just PBS injected versus AAV injected, all those parameters are the same. There's no significant difference. So we know in wild type animal, mice, this injection at high dose is safe. And to be sure, also measure the behavior of those animals. And rotorol test, Bands beam test, maze test, we measure all of them. And we didn't see any changes between treated and untreated animal. The next is really to look at about distribution. That is, you inject in the ear, through in the ear, your A product. Then after injection, where can you pick up the AAV from different tissues? So this actually is a very important point, because in some protein product, they may be important for function in that particular cell, but they could be toxic in different cell types. So we really need to know where this AAV goes, and if so, that give us idea in the future. We may pay attention to those cell types to see if any pathology coming from the cell by the various tests. So this is what I think is really revealing for all of us. That is, we did in the ear injection. Of course, we find the highest AAV, we can detect them from injected ear, but we can also detect from the brain, from contralateral ear, uninjected ear, spinal cord, and in other cases is many log lower than injected ear. But in the brain, we can detect about half, 5 times lower than. So that means the injection, the AAV into the ear does transduce the cell in your brain. So that's really one of the key findings in our study. Then we look at the pathology. We look at different tissues, multiple tissue. We sample from untreated or vehicle treated versus AV injected. We didn't see any changes. And these are to the monkey study, non-human primate. So we injected into the same product into the monkey in a year and look at the in the year distribution of the AAV, and we can see the expression. Actually, in a year is more widespread. One that we see the in the hair cell, but also see some in the out hair cell. So then about distribution, what do we see? If we inject in a year, and we indeed can detect the AAV from the brain, from liver, spinal cord. So this, but in other tissues, are really non-existent. So this study actually between mouse and non-human primate, to some degree, there is a correlation. And of course, we don't really know what's in human, right? We can't really take a human tissue, but this really gives us indication that with the mouse data, we can get some really good human, non-human primate data. There are, especially among the tissue from brain, liver, spinal cord, we know there's a really good correlation. So this will help us for the future, study some other gene therapies. So now we go to the trial. And so the protocol, well, first the recruitment of the patient. So we decide to recruit patient 1 to 18 years old. And the idea is to go to from old to young, and the dose from low to high, and then they'll be improved. So this is very interesting. The work was done really, as I said, the work was really initiated, spearheaded by Eli Shu in Shanghai Fudan University and Hospital. And Eli was my fellow in my second year. And one of the really amazing things is when we put out the announcement in China, so we want to, because we always know from beginning, we need to get enough patient. And we also know the difficulty in different companies in the US in actually getting the patient. So when we put out the announcement in China, overnight, we got hundreds of patients respond to the announcement. And so we use a criteria to screen and the patient. So from there, we found initially 6 patients are eligible for the test. So the study we're trying to do, follow this protocol. That is, we first low dose in 1 patient. Then afterwards, we, after injection, we first test, does that have a drug limiting factor? Is there any adverse effect? 6 weeks later. If it says there's no drug-related limiting factor, then we move on to the higher dose. And so we do this sequentially. So this is really for the safety reason, because we want to be sure it's after safe. It's the first in human gene therapy trial for genetic deficiency. We want to be sure after first patient dose, it's safe. We don't see any major adverse effect before we move on to next patient. So that's why we use this the chart, this group. If we see anything like this, for example, if we see major adverse effect, we'll stop there. We may just, we will not move on to next dose, or we'll use a reduced dose. So in a year, surgery was done by, Eli, Dr. Shu, who used a external auditory canal and use endoscopic approach to deliver the gene product. So the first use AAV is we always worry about is any antibody, built-in antibody. We all know from vaccine study, everything else, if the AAV, if you have antibody pre-existing, neutralize the antibody, that could neutralize the antibody, then you render your treatment ineffective. So in this case, we always measure the antibody in those patients. In this case, we actually didn't see the heightened neutralizing antibody in the patient. So, but after injection, we can clearly see all the neutralizing antibody being produced against AAV1, sorry. And you can see the number actually goes up from 6 weeks up to 13 weeks. We measure them. But then we look at the interferon gamma, vector DNA, all the things, really measure immune response or the DNA circulation, and 1 week later, we actually don't see any. So that means there's a very limited amount of AAV DNA being circulated. There's no real immune response. About those adverse effect, we see some, very mild, majority of the grade 1, grade 2 adverse effect, and then all sort of resolved without any further treatment. So in a sense, to us, it's really reassuring. The whole process is very safe. And the transcanal approach actually turned out after injection. This is an injected year and injected year compared to uninjected year. And the tympanic membrane, they just healed nicely. There's never been any issue. So we know this procedure is really minimally invasive and also very effective. So the result. So we, of course, we really didn't know what to expect, right? At the beginning, it's the first in human study, and there's so much we didn't know, from animal to human. Every step could go wrong, but to our surprise, pleasant surprise, and we see a major hearing recovery. So before the treatment, which is baseline here, and this is with a click and some evocation, and we don't see any response. But after the treatment, you can see the ABI, SSR, PDA, they all shift together. That is, they go from, this is by different weeks, from 4 weeks to 26 weeks, they're all getting progressively better, okay? And the best by 26 weeks, which is half a year, they from over 95 dB to, to 45 dB. And we know this therapy is therapeutic is beneficial because we use the same guideline with 10 dB reduction average threshold to consider the beneficial. So we injected 6 patients in total. And in 1 patient, actually, we didn't see any effect. And this one's completely without any response. But others, patients all react similarly to the first patient. Oh, by the way, the first patient was done by the lower dose, and 10 to 9. Now we move to a higher dose. The reason for that being, we know from the animal study, as I mentioned earlier on, the higher dose will give you a better result. And we know that no dose didn't have any toxicity. And so want to see if we give a higher dose, will potentially can give us, more benefit. But indeed, we see the after treatment in all the patients, they have hearing recovered before the complete, profound deaf or complete deafness, and afterwards they all recovered. Depend on each patient from 55 dB to 48 dB. This is average cross-board, the hearing ABR threshold recovery. But in some cases, like this one, high frequency, you have a much better hearing recovery. And this one, in low frequency, you have a recovery close to 20 dB. Okay, so really, these two processes are truly amazing to see something like this. And this result to a degree really match what we saw in the animal study. And that's something we didn't expect either. So if you combine all the patient, 5 out of 6, we exclude the one didn't work. And what we can learn, that is, 1, we see the recovery across all frequencies, from low to high frequencies, and the recovery is time dependent. That is, the time goes on, the recovery is getting better. There's 4 weeks, 6 weeks, 13 weeks, 26 weeks. Okay, so it's really remarkable in our hand, to us, is that the patient can have such great recovery. Then, as a result, we also test some of the speech, you know, in the ambient noise environment, the speech recognition, and I don't want to go through the detail, but at least in the patient, we can be measured. If you compare it with baseline, we all see improvement in the treated patient. And oh, by the way, those patients have been treated 1 year. Okay, this is a single unilateral injection. What about the DPoE? So the DPoE, those patients, we know DPoE, they have DPoE because inner hair cell, you know, otoferlin really affect the inner hair cell, we're not outer hair cell specific, so they have a DPoE. But after surgery, we did see a little bit of a dip in the DPoE, especially in the early time, but gradually they'll kind of recover to or regress to what the pre-treatment. And so here I just want to show you some of the video, what the patient, what they look like, how they respond to the sun. So this is a patient, there's some words you can read, and so this is before treatment. There's no response. So this is 4 weeks. This patient could start respond. So that's 14 weeks.
我爱妈妈，重新说我。
And the second patient is a 1-year-old when he was injected. Then 6 months later.
，Hello， 你叫妈妈，妈妈。
小鸡怎么叫啊？小鸡怎么叫？叫妈妈，妈妈，叫爸爸，爸爸，叫奶奶，爷爷，爸爸，苹果，香蕉，
He even learned to speak some English. Okay, so this sorry. So from this study, we actually learned we can use the gene therapy to treat genetic deafness, DFNB9, and we show the hearing restoration anywhere between 50 and 40 to 57 dB in the average, but in some frequencies, much better restoration was achieved. And we saw the speech perception improved in the children, and there's no adverse effect after the treatment. Okay, so the hearing restoration is really in a time-dependent manner. The time goes on, is actually better. So we are following up for longer time to see what's the ceiling and how far it can go. So that's really the study we published recently, but I want to share some another set of study we just recently completed, and actually the paper will be, hopefully will be coming out soon. This is the first study was done unilateral injection. So now we have done bilateral AAV injection to the both ears. So why do we do that? Of course, because bilateral, you can have a better speech and perception in noise environment, and importantly, you can have sound localization capability. So that's what we want to do. So we, from the, follow the same protocol we used in the previous screening, we identify an additional DFNB patient, and the age is from 1 to 10 years old. And none of them had a cochlear implant because they both had to be, to be treated. They all have the mutation. Before the treatment, they all have profound hearing loss. So similar to the previous study, after we did the injection in both ears, we measure the adverse effect, we measure the antibody and gamma interferon. In none of the cases we saw any serious adverse effect or immune response or vector DNA shows even we double the amount of material because now we're doing 2-year injection. And on the safety side, is still very good. We still have very high safety profile. And what about hearing? So now this patient we followed for half a year. And so this is the right ear, this is the left ear, and by ABR, ASR. And you can see in both cases, this is before the treatment and after treatment. They improve, very similar to the single injection, what we saw early on. And the average is 50, 60, and the two are very similar. The 2 years are similar of the treatment. So if you look at the rest of the patient, look at in a year, one is we all see hearing restoration, right? From complete deafness, profound, to different, sort of a different level, the restoration, a different level. But one of the very interesting thing to us is there are certain variation, but the variation is really patient dependent. For example, for this one, you see the recovery primarily in the low frequencies and not very much in the high frequency, and in both ears, right and left ear. Okay, so this is really very different from other individual. Like this one recover across the board, and the recovery and also very similar. And so you see a very similar pattern in both ears. So this to us really shows there's an individual component which may be determined genetically or some other things, but clearly the consistency between 2 years. So that is, if you inject both ears, you probably can expect to see similar result, but there will be a wider, broader individual difference between one individual to the other. So overall, depends on different individual, different years. So someone recover better than others. So like this one, the 40, 50, and 50, 60, and this one didn't recover. We know this is primarily because high frequency didn't recover, but low frequency did recover. And in terms of speech and perception and sound localization, they actually all recovered. They all improved speech perception as well as sound localization capability. So this is the other video I want to just show you. So this is bilateral injection, after bilateral injection. So you can see you respond to the left and right, the sound coming from left and right. Okay, so now I'll show you is a 10-year-old after injection. And what you notice in the previous video clips, the children are very young. So actually their speech is rather, recovered speech is very well, and they can learn and speak very quickly. But this is a 10-year-old, it can recover some speech, but clearly there's a major difference between this one with others.
爸爸一妈妈
Okay, so they really conclude the second, the bilateral gene therapy for autoimmune and DFNB patient. So this is the first bilateral gene therapy, and again, there's no drug limiting toxicity or serious adverse effect, and we see hearing recovery in all the 5 patients, as well as speech perception and sound localization and being restored. So we can't be happier than about the result we've achieved so far. What does it hold for the future? Really, that's something constantly on our mind. For autoimmune study, we'll continue to do more patients with different age group with longer follow-up, and we want to do more dose escalation because we want to see even a higher dose can we get an even better result. And the other thing we'd like to do is because some of the patients, even they didn't have cochlear implant, we only inject 1 year. We want to evaluate whether it's possible to inject other year. But the reason for that is we know after first injection, the patient will develop neutralizing antibodies. So really, this is to evaluate if such a secondary sequential injection is possible. And there's a precedent to that. In the retina gene therapy, people actually have done repetitive injection after first dose, wait for some time to a second dose, even though they can still see the neutralizing antibody being raised in the body, but the second one actually improve upon the first one. So it'll be very interesting for us to find out what's going on. And there's a different strategy for the AAV, dual AAV, we could look into. And one really important study we are currently conducting is really do a direct comparison between cochlear implant and gene therapy. What are pros and cons? What do we learn, especially in variety, hear the nuances of speech, in the noise, in sound localization, in music appreciation, all those factors is really important to patient. We'd like to find out how is a gene therapy compared to a cochlear implant. So the next one really for us is how applicable is the gene therapy to other genetic hearing loss? Looking at our data, someone would draw a conclusion, geez, seems very easy and could work with others. So I want to just give you some thoughts on that. That is, we know retina, blindness, they have gene therapy. The first Leber congenital amaurosis for RPE65, the successful trial was done in 2008, and Luxturna, which is FDA approved gene therapy in 2017. So it's the same. When it happened, everyone thought it would be a piece of cake, develop gene therapy for other retinal diseases. But up to now, this is the result. All the gene therapy trial failed or terminated for, one lack of efficacy is one of the major reasons. So what we really want to learn from this suggests the path to gene therapy is not straightforward. Though a lot of things we don't know, we need to learn. So what are the factors we need to consider for genetic hearing loss? Is we need to know what type of hearing loss, recessive dominant hyperinsufficiency, they all had to be treated separately. How progression disease, time intervention, treatment outcome are correlated. If a patient who develop a congenital deafness, if the cells are severe damaged, I think it's very hard to see any treatment effect. The otopharynx, we benefit from the fact even the patient are bone deaf, but the cell structure is all intact. That's why they can respond to gene therapy. But for others, Mountain 7A, for example, likely hair cell with so severe damage, I think it will be almost impossible to develop treatment. So we need to develop a suitable animal model. We, as well as others, have developed different genetic model in mice. We have shown we can rescue hearing in this mouse model. But today, the 23 genes have been studied, but only 4 genes was shown to be effective in adult. The rest of them were in the neonatal animal. But when they moved to adult, actually didn't work. So this really that tells us those models, we have to be really careful because that suggests if you do them in the mature in a year, similar therapy may not work until we have better evidence to show otherwise. So of course, we need to find the patient population to be able to do this study. But we do have an advantage in a year. So in a year, it's highly conserved across many species. That's why mouse model is such terrific for developing treatment. We want to have very small numbers of the target. You know, if you look at this hair cell, it's compared to retina is 500,000 times full in terms of number. So targeting hair cells is far more efficient than targeting the retina cells. And the enclosed structure of in a year will enhance the safety and also use very little material. And of course, in a year has the environment with the fluid that really help us to transduce whatever we deliver from the base to the apex to achieve the effect. So I would say the future is really bright for all of us, despite some of those issues, we need to work through them. But for all of you, especially young clinician, you have a great future for the patient. And finally, I would really like acknowledge Eli Shu, who has really spearheaded, initiated the whole study, and the team in China has performed heroic effort to all the studies, as well the collaborators, other groups. And that's it. Thank you very much.